Hello and welcome. This is fetal echocardiography, still continuing on with human heart embryology, and this is week 2. Just a reminder, if you haven't finished week 1, remember there was two parts to that, 1A and 1B. This week, of course, just one lecture, lecture 2, week 2, and continuing on with embryology. So this is our outline for this week. We're going to talk about partitioning of the bulbus cordus and the truncus arteriosus. What does the bulbus cordus and truncus arteriosus form as they form from that primitive heart tube? What structures do they form, and what do they form in adult life? Then we're going to talk about arch formation and all the different arches. So we'll talk about the importance of those arch structures and which ones develop into things that we see in the fetus. And then we're going to talk about, and we talked a little bit about this last week too, of atrioventricular valve formation. We just touched upon it when we were talking about AV cushion and how that forms and how that divides, the right side and the left side. Then we're going to talk about semilunar valve formation. How does the aortic valve develop and the pulmonic or pulmonary valve develop? We're going to touch a little bit upon coronary artery development, and then lastly we're going to talk about fetal circulation. And we're just going to talk about fetal part, but we won't really go into post birth, so things that we look at in fetal echocardiography. So I want to start with this slide. And this slide is called Moving On Up. And so last week we talked about, what happened to the primitive, the sinus venosus, the primitive atria, the primitive ventricles. Well, we're moving up that heart tube, and now we're going to talk about the bulbus cordus and the truncus arteriosus. And this kind of moving on up was a theme song from kind of a hit TV show here in the States, back in the 70s and 80s. The show was called In the Family, or All in the Family, and it was a spin-off of, a spin-off of this couple, and this couple was named George and Louise, and you can see them on the left-hand side of the screen, and they're moving to this swanky high-rise building. And so they're moving on up kind of the social or social-economic ladder. And so it's a comedy that lasted about 10 years here in the States. Again, the guy was kind of this rude kind of guy that thinks his wealth should afford him the finer things in life and get him what he wants, and his wife kind of keeps him level-headed. But their theme song for this All in the Family was called Moving On Up. And so I thought it was appropriate because we are moving on up through the heart tube. So let's talk about partitioning of the truncus arteriosus. So during the 5th week, active proliferation of the mesenchymal cells in the walls of the bulbus cordus result in this formation of the bulbar ridges. And last week we talked about those bulbar ridges and how they form, closing that interventricular foramen in that ventricle, right? Partitioning the left and right ventricle. We also talked about how that is the membranous part of the ventricular septum or the interventricular septum. So at the same time that these bulbar ridges are forming in the bulbus cordus, they're also forming in the truncus arteriosus. And these ridges are largely derived from the narrow crest mesenchymal cells. And so these cells, or these narrow crest cells, kind of migrate through the primordial pharynx and pharyngeal arches to reach these ridges. And as this occurs, the bulbar and truncal ridges undergo a spinning or 100-degree spiraling. Okay, so we'll talk about this. We have some images coming up here talking about how that spirals, right? And if you think about a wet rag and one end you twist one way, you twist clockwise, the other way you twist counterclockwise to get that water out of a rag or a towel. Well, that's what these ridges kind of undergo. They twist, they spiral. And the spiral orientation of these ridges, and it's caused in part by the streaming of blood flow through the ventricles, results in this formation of the spiral aorticopulmonary septum when these ridges fuse. So these ridges grow and fuse to each other and again form that septum within the truncus arteriosus. This septum divides the bulbus cordis and the truncus arteriosus into two arterial channels. The ascending aorta is one of those channels, and then the pulmonary trunk, or the pulmonary system or circuit, is that second channel. And because of the spiraling that this goes, the spiraling, that 180-degree spiraling of the aorticopulmonary septum, the pulmonary trunk twists around the ascending aorta. So again, at the fifth week, we can see these truncal and bulbar ridges forming, right? This is going to be the bulbus cordis, a little bit more superior. Remember, that's going to be the truncus arteriosus. And so as these form, remember, they're going through a spiraling, and I'll show you, we have this picture kind of blown up so you can see it a little bit more closely, but this is a transverse cut sections of the truncus arteriosus and the bulbus cordis. And again, just pay attention to where these ridges form. So we can see cut plane 1, cut plane 2, and cut plane 3. And as we look at that, we can see that it kind of makes this X, right? If we follow this bulbar ridge from kind of the base or more inferior, and this is going to be more superior, right? 1's up here, 3's down here. We can follow that bulbar ridge. So here's the bulbar ridge, here's the truncal ridge, and as those form, again, we get this spiraling, or that aorticopulmonary septum. Again, this would, if this was coming off the right ventricle, this would be the pulmonary circuit. This is off the left ventricle, this would be the aorta circuit. So at 6 weeks, the ventral aspect of the heart, after partitioning of the truncus arteriosus, we see that now we have this pulmonary trunk and aorta. And this pulmonary and aorta trunk, you can see again those same cut planes. Now there's this septum, this aorticopulmonary septum that's forming. And as it's twisting 180 degrees, right, we can see the pulmonary trunk, twisting on itself. Now these sections are newly formed, the aorta and the pulmonary trunk, showing that septum, and the ventral wall of the heart and the pulmonary trunk have been removed to show again that aorticopulmonary septum. All right, so now as we look at this, this is the right aorta or AV canal. So AV canal, this is going to be the right side of the heart. So as it's pumping blood out, now we have the pulmonary system, right? So pulmonary artery. Notice we don't have a valve just yet. It's too early. And then on the left side, again, this is going to be the aorta. But we can see here is that aortic or aorticopulmonary septum. Again, just looking at this kind of enlarged to see all the different sections as those ridges come together, right? They're growing towards each other. They form this septum. Again, that spiral formation, now partitioning of that truncus arteriosus and superior part of the bulbous cordis. So from that partitioning of the truncus arteriosus that forms the great arteries, again the ascending aorta and the pulmonary trunk, they twist around each other as they leave the heart. So again, just pointing out the pulmonary trunk. So this would be later be the left, really the main pulmonary artery, and it gives rise to the left pulmonary artery and the right pulmonary artery. Now aorta is going to come, go kind of underneath the pulmonary trunk, right? So we have that, really the pulmonary trunk is more anterior than the aorta, right? So that's more anterior. And then we have the ascending aorta, aortic arch, and then descending. But that's later. So what do we talk about? Let's talk about the bulbous cordis. So now, really the bulbous cordis is incorporated into the walls of the definitive kind of ventricles. So in the right ventricle, the bulbous cordis represents really the infundibulum or the conus arteriosus, which is the origin of the pulmonary trunk. In that infundibulum is kind of that RVOT or outflow tract of the right ventricle. On the left side, the bulbous cordis again is incorporated into the walls of the left ventricle. On the left side, it forms the walls of the aortic vestibule and part of the ventricular cavity just inferior to the aortic valve. And the left ventricular outflow tract, or LVOT for short. Again, if we follow this, we can see that we'll go more into detail with some abnormalities, right? So abnormalities with this would be normal as they spin. Atrial or aortical pulmonary septum is coming in the middle of this, and as it forms, we have equal aorta and equal pulmonary trunk. But we can see that there's underdevelopment in certain areas if these ridges don't come in the middle, or if there's really inappropriate growth, right? So now we have a stenotic pulmonary trunk or a stenotic aorta, depending on where these ridges form. There could be dilatation of the aorta, dilatation of the pulmonary artery, and a stenotic or small aorta in the example here in C. And B, we see an example of a stenotic pulmonary trunk. So let's talk about arch formation. And so we're going to continue on and moving on up. So the pharyngeal arch arteries form and start to develop during the 4th week after conception. And you can see that these arches, or these pharyngeal arches or arch arteries, form from this aortic sac. So you can see in this fetus here, we can see the arches, first through the 3rd arch, and here's that aortic sac. Again, here's going to be the heart from really sinus venosus to truncus arteriosus. And although there are 6 pairs of arch arteries that usually develop, they're not persistent, or they're not present at the same time. By the time that the 6th pair of arches has formed, the first 2 pairs of arches have disappeared. And so as this takes place from the 4th week to the 8th week, that 8th week is kind of that final transformation. And so the 8th week, the primordial pharyngeal arch arterial pattern is transformed into the final fetal arterial arrangement. And that's what we're going to go through. So we're going to go through each arch, 1 through 6, and see what these arches develop into. So you can see from this slide here, this is an embryo that's 37 days old, And it shows, again, here's the heart, here's the aortic sac, and now we're seeing this degeneration of the first two arches, and now we have the third, fourth, and sixth arch. So let's kind of step through each one. So the first pair of pharyngeal arch arteries, these are arteries that disappear, but remnants still remain, and they remain and form part of the maximal or maxillary arteries. They supply the ears, the teeth, the muscles of the eye and face. And these arches or these arteries may also contribute to formation of the external carotid arteries, or ECAs, if you are familiar with carotid imaging or vascular imaging. So the second pair disappeared just like the first, but the second pair of pharyngeal arch arteries, there are remnants that we can see in the fetus, or remnants of the second pair of pharyngeal arch arteries. And they form kind of these arteries or small vessels within the ear, the middle ear. And so the dorsal parts of these arteries persist and forms the stems of the stapedal arteries, which are small vessels that run through the ring of the stapes, or the small bone in the middle ear. So even though they disappear, there are remnants of the second pair of arch arteries. So as we look at this this branch kind of here, so here would be the truncus arteriosus. We can see that it's partially divided, not fully divided into the aorta and pulmonary trunk. But here would be the first two arch arteries, again, have disappeared, and we talked about just what they formed. And as we talk about the third, fourth, and fifth, or third, fourth, and sixth, you can see the fifth we'll talk about here too, but we can see at 6 weeks, these two first and second pairs have largely disappeared. Well, what about the third pair? As we keep going down the trunk here, going down these arch arteries. Well, the third pair, the proximal parts of these arteries form the common carotid arteries. Again, the carotid arteries supply blood to the head, right? The distal parts, so that was the proximal parts, the distal parts of these arteries join with the dorsal aorta to form the internal carotid arteries, which supply the middle ears, orbits, brain, meninges, and the pituitary gland. So very important. These, again, are forming, again, head and neck vessels. And so as we get further and further along in the weeks of embryology, we can see, again, here's our first and second pair that have disappeared. We can see parts, again, forming into the external and internal carotid artery, right? That's what we were just talked about with the third one. And we're going to move to the fourth and sixth. And as this takes place, we can see that now, if you kind of glance from far away, we can see what's happening. You know, we're going to see disappearance of some of these arches, be right or left, and then forming, again, this arterial trunk. Well, what about the fourth pair? The fourth pair, the left fourth arch artery, forms part of the arch of the aorta, or the transverse artery, or transverse aorta. The proximal part of the artery develops from the aortic sac, and then the distal part is derived from the left dorsal aorta. The right fourth arch artery becomes the proximal part of the right subclavian artery. So the left, again, part of the arch, the right part of the right subclavian artery. And the distal part of the right subclavian artery forms from the right dorsal aorta and right seventh intersegmental. So the left subclavian artery is not derived from the pharyngeal arch arteries. It's actually formed from the left seventh intersegmental artery, just like what we talked about with the right seventh intersegmental artery just a second ago. And here we have that picture of that. So again, looking at the fourth, what does it know? What parts of that fourth aortic arch, what does that form? Okay, so here demonstrating that left, right? So left being the arch, the right fourth being that right subclavian artery, and here would be those, again, those kind of segmental arch arteries or arteries. Again, this is another side kind of view of as we look at parts of the arch here in the formation. Remember that blue, what was that? Well, that was the truncus arteriosus, right? Again, forming from really top down, right? So 1, 2 have disappeared. There's remnants. Here's 3. This is going to be 4, right? And then 5 and 6 we'll talk about here in a second. So look at these different portions and what they're starting to develop into. So we've gone through 1 through 4, and we talked a little bit about the fifth pair and how we don't see that, but really the fifth pair of pharyngeal arch arteries, approximately about 50% of the time, the fifth pair of arteries consists of a rudimentary vessel that soon degenerates, so it disappears, and leaves no vascular derivatives, so meaning that it's not leaving any remnants or formations. And the other 50% of people, really these fifth pair of arches really don't exist or don't develop at all. So they either develop and then degenerate, or they don't develop at all. So again, this would be where the fifth would be, right? So if they do form, they then degenerate. Okay. And then lastly, the sixth pair of arches. So if we look at the left sixth arch or artery, that develops into kind of the proximal part. So the proximal part of the artery persists as the proximal part of the left pulmonary artery, and the distal part of that sixth pair, or left sixth artery, passes from the left pulmonary artery to the dorsal aorta, and it forms that prenatal shunt, as we talk about with fetal circulation. That is called the ductus arteriosus. So proximal part of that left sixth forms part of the pulmonary artery, the left pulmonary artery. The distal part forms the ductus arteriosus. Well, what about the right side of the sixth pair or sixth artery? The right sixth artery develops into the proximal part of the right pulmonary artery, and then usually, or the distal part then degenerates. So the proximal part persists and the distal part degenerates. Okay, so here would be, if we see here's that truncus arteriosus, the division has occurred, right? The spiraling. So now there's that septum, and now they're formed the pulmonary trunk and the aorta, right? So now as we look at that, the left side is going to form, again, this left pulmonary artery, and a little bit of the right pulmonary, or the right side is going to form the right pulmonary artery, and then we're going to have this communication here that we'll show here in a second. Okay, so this would be, again, just another cut plane through here, and we're the lightest pair, really, of pink here we're seeing is the um, sixth arch. So as we look at that, here would be the kind of bifurcation of the pulmonary artery, left and right. And then this would be after the baby is born, we have this ductus arteriosus turn into ligamentum arteriosum. We don't need to know that right now, but remember that is the distal part of that left sixth arch. And so this would probably be the better picture of that. Again, the ductus arteriosus. This would be after birth, and this ductus arteriosus becomes a ligamentum arteriosum because we don't need that communication there. So again, these are all images taken from the Human Development chapter, chapter 13. Or another good resource and reference going through all of the cardiovascular embryology. Again, just kind of blown up here. And we can see now this is a good way of just looking at what each one becomes. And it's color-coded so that we can see what remnants of the third, fourth, and sixth arch develop into. And so as they go through development from 4th week to 8th week, that would be kind of A through C, right? First starting with the first and second, then all the way through the 6th aortic arch or pharyngeal arch artery. And as that happens, this is where we're stopping in fetal echocardiography, but after the baby is born, then we get, again, this ligamentum arteriosum. Okay? So know all these parts, know all the parts of these remnants, and really, if you can answer these 3 questions, these are kind of board questions of what happens during embryology, and in particular, board questions for here in the States. You know, we have to think about what these become. So, what happens to the third aortic arch? What does it become? What happens to the 4th aortic arch? And what happens to the 6th aortic arch? So, think back of just from, I guess, the last 10 minutes of talking about what these arch arteries become, and spend time just answering these questions. Next, we're going to talk about our atrioventricular valve formation and the semilunar valve formation, and how this, how our valves really form. And as we go through this, semilunar valves now are going to be our pulmonary valve and our aortic valve. Atrioventricular valves we've talked about a little bit already, but those are your tricuspid and your mitral valve. So we did talk a little bit about this, but towards the end of the 4th week, those atrioventricular endocardial cushions form. And remember, they form from the dorsal and ventral walls of the AV canal. They come together. Those cushions develop from a specialized extracellular matrix, cardiac jelly, as well as those narrow crest cells. And as those cushions come together, they divide, kind of really start to divide the right side and the left side. And just as a review too, as these masses of tissues invade the mesenchymal cells during the 5th week, those cushions approach each other and divide into the right and left channels. These channels partially separate the primordial atrium, so left side and right side, from the primordial ventricle, and the endocardial cushions form or function as atrioventricular valves as well. So now we start to see blood flow, right, as we talked about, coming in and then kind of dividing. You can see now our chambers are starting to develop. So the septal valves of our atrioventricular cardiac valves are derived from the fusion of the superior and inferior endocardial cushions. And they form these mural leaflets. Mural leaflets are formed from these thin, flattened layers of the wall and are these from mesenchymal tissues or mesenchymal cells in their origin. So they form from those mesenchymal cells. After induction, signals emanate from the myocardium of that atrioventricular canal. A segment of the inner endocardial cells undergoes epithelial mesenchymal transformation, and the resulting cells then invade this extracellular matrix. In this transformation of those atrioventricular cushions contribute to the formation of the valves and the membranous septa of the heart. So it's thought that in the development of these atrioventricular valves that there's a growth factor, beta growth factor, this transforming growth factor, beta or TGF, beta 1 and beta 2. There's also components of this bone morphogenic proteins, BMP 2A and 4. Also, zinc finger protein slug and an active receptor like kinase have been reported to be involved in this epithelial mesenchymal transformation and the formation of these endocardial cushions. And so around these endocardial cushions, the atrioventricular valves develop. And they develop from these localized perforations of tissues around those atrioventricular canals. And these valves, will start with the tricuspid valve. The leaflets of the tricuspid valve go through this process of delamitation or delaminate from the myocardial walls of that primary tube. And from that primary tube, it is then incorporating the endocardial cushions in their substance. And so this will be very similar to the mitral valve too, but on the cavity on the left atrium, there's this it's continuous with that of the development of the left ventricular from the onset. So this is going on as those AV cushions have formed, and this delamination process of the valves undergo. So just like the left side and right side, that atrioventricular canal becomes a part of the atrium, and so now we have this division between the atrium and the ventricle, and this forms this plane of insulation from the atrium to the ventricles. As we talked about too with the leaflets of the mitral valve, this goes under a delamination process or delaminates within the inlet of the component of the left ventricle in the fashion just comparable to the formation or compared to formation of the tricuspid valve. So it goes under that formation within, again, left side would create the mitral valve, right side would create the tricuspid valve. And here we can see that delaminating process. The arrows are pointing to, we're looking at the right side of the heart here. So this is the right atrium, right ventricle. And we can see this delamination process. Here is going to be, again, the atrioventricular canal, and then the right side. All right, so there's communication from the right atrium to the right ventricle, and this is that area of delamination. So this formation is going to, again, separate between the right atrium and the right ventricle, but this area actually becomes part of this fibrous tissue. And as we look at this fibrous tissue and the growth of that, it becomes elongated. Okay, as it's pulling away from the the walls of the right ventricle here and the endocardial cushion, um, forming the tricuspid valve, and the same thing is happening on the left side. So here we go. We have this at 5 weeks. We can see this is the area that we're looking at the right side and the left side. Here's the left atrioventricular canal. Here's the right atrioventricular canal. They go under. They undergo swelling, and then as those areas undergo swelling, this is when those transforming growth factors are coming in, and beta or trans growth factor beta 1 and 2, and all those components coming in, activating those areas of the mesenchymal cells. And from that, here's at 6 weeks. We can still see other processes going on, but again, we see that these areas are starting to delaminate, right? We see the still communication here between right and left ventricle and right and left atrium, but again, this is the area that that is forming the valves. So here we can see at week 7 the development of the mitral valve, the development of the tricuspid valve, and from that delamination, we can see again anterior leaflet, posterior leaflet of the mitral valve. This looks like to be septal, and hard to tell if this is anterior posterior leaflet of the tricuspid valve. And then at week 20, this is again taken from that Developing Human textbook, we can see all aspects of the tricuspid valve and the mitral valve, and then the formation of the papillary muscles and the chordae tendineae. So this is the process. This is the swelling, activation of those cells to form fibrous tissue forming those leaflets of the atrioventricular valves. So the atrioventricular valves develop during late embryology, and there is thought to have postnatal stages that actually have this elongation of the valves, the condensation, elongation, and formations of these nodular thickenings on the valve, and that's postnatal. Okay, so these valves are continuing to develop and grow. Well, what about the chordae tendineae and the other aspects of the papillary muscles that are forming with the atrioventricular canals or valves? Atrioventricular valves have these apparatus, right? The mitral valve apparatus, tricuspid valve apparatus that include the chordae tendineae and papillary muscles. Right side and left side both have chordae tendineae and papillary muscles. And so what happens there is we have this cavitation of the ventricular walls, and this forms these spongy masses of muscle bundles, or the chordae tendineae or trabecula carneae, and these form again papillary muscles and these tendinous cords or chordae tendineae, and these cords run from the papillary muscles to the atrioventricular valves. So again, right side and left side both have papillary muscles and chordae tendineae. So here's that cavitation process, and then we start to see again the formation of cords and papillary muscles. Cords and papillary muscles, right side and left side. Now we'll go in detail about more mitral valve abnormalities as the weeks go on, but we can have some mitral valve abnormalities. We can have, if there's abnormal compaction of the trabecular layer, this can form a single papillary muscle or parachute mitral valve, where there's only a single papillary muscle, usually Under normal circumstances, we have two papillary muscles, posteromedial and anterolateral papillary muscle. If they don't form correctly, we have a single that would cause problems for the mitral valve. Usually problems with either opening and closing of that mitral valve causing regurgitation or stenosis. If there's failure for the cords or chordae tendineae to form, this results in a hammock or arcade mitral valve, where these chordae are these large papillary muscles that abut right up to the mitral valve. And so arcade lesions, mitral valve arcade, is another abnormality that is seen. And again, because of abnormal embryology development of the cords and papillary muscle. Same thing for the right side. Right side, we can see an abnormality called Ebstein's. Ebstein's abnormality is a lack of delamination of the septal and inferior leaflets, or posterior leaflets of the tricuspid valve. And these tricuspid valve abnormalities, or Ebstein's abnormality. We see actually the valve, we have atrialization of the right atrium, so really the right heart, where we have a large right atrium, and that tricuspid valve is seated closer to the apex of the ventricles. So it doesn't sit kind of on that same plane. Later we'll talk about the cardiac crux, but it sits further towards the apex, and there's an abnormality where we'd have atrialization again of the right side of the heart. So a huge right atrium, small right ventricle. Again, alignment of the tricuspid valve causing regurgitation. So what about the semilunar valves? We've talked about the atrioventricular valves. Let's talk about the semilunar valves. So now we talked about the truncus arteriosus already in the bulbus cordus, right? We talked about partitioning of those. And so the truncus arteriosus is nearly completed. When it's nearly completed, the semilunar valves begin to develop, and they develop from three swellings of subendocardial tissue around the orifices of the aorta and pulmonary trunk. And so we can see that here. Remember, we talked already about these truncal ridges, these bulbar ridges, and now they're twisting, and as they twist, they form the pulmonary trunk and the aorta. Well, we have these swellings, right? These swellings on the right side and left side, and as these swellings occur, we have these formations of the semilunar valves. And so these are from these neurocrest cells contribute to the tissue. So they are developing into these aortic valve and pulmonary valves, and they'll be shaped, and each one of these valves will have three thin-walled cusps. And so as we go through these different cut planes, right, if we're taking these sections, this is a transverse section, or a section cut through, not a transverse, but longitudinal cross section through the truncus arteriosus and bulbus cordus, again showing the swelling of the valves. And now we're taking this transverse cut through the bulbus cordus. This is that section here. And as you see the swelling, they will start to fuse. Right here, there are the fusion of the bulbar ridges. And now we have, once that occurs, now we have an aorta and a trunk, or pulmonary artery, if you will. And now these are going to form and swell and change into develop into the pulmonary valve and the aortic valve. And so now, once we have formation of the aorta and the pulmonary trunk, we can see that there's rotation, right? Still rotation. And now we have the aorta And so the aorta, we have anterior cusp, or the right coronary cusp, left coronary cusp, and non-coronary cusp. Here on the pulmonary valve, we're going to have anterior, left, and right cusps. Right? So as this keeps twisting or rotation, this is the rotation for the adult. In echocardiography, we're going to see that opposite, right, as we look at the rotation and relationship with those valves. Here's those longitudinal sections, again, of valvular swelling. These valvular swelling then start to hollow out stages, and that's what is, as they hollow out, you can see that the arrows become thin. These valve swellings become thinner and form these valve cusps. Okay, so here is just another image, again, from that Developing Human book, looking at, again, all stages and really in time, from really B to E, and then the swelling of that endocardium, or the valve swelling, forming the cusps of those valves. So let's move on from valves and valve formation to coronary artery development. And our coronary arteries feed the heart. And so coronary is actually derived from the Latin word from crown. And our coronary arteries sit on the heart as a crown. So they are the first two branches after the heart. And in the adult population, they are the crowning subject. And I mean they're the crowning subject because are due to coronary artery disease. Now, coronary artery disease is a huge epidemic in the world today. Not only are there modifiable risk factors, but there are non-modifiable risk factors. But adults, we start to actually get coronary artery disease as early as in your 20s. Usually we don't see it until the 4th, 5th, and 6th and later decades of life. And that comes from narrowing of the lumen of those coronary arteries. It's still important in fetal and pediatric situations because there are a lot of abnormalities that can happen too in congenital heart disease, not necessarily due to coronary artery disease, but it's still important in adults and in babies. And so let's talk about development. And so the blood, or the heart, receives blood. Before there's development of the coronary arteries, it still receives blood from the mother due to this loosely packed myocardium, and that loosely packed myocardium has all these sinusoids or non-compacted layers, and so these sinusoids actually feed the myocardium throughout the heart cavitary. As the myocardium compacts and becomes compacted myocardium, like what we see normally on an echocardiogram, and if you're interested, there's a lot of work done on non-compaction of the myocardium, but the compacted layers, once that myocardium compacts, that's when we start to see veins and arteries develop. And so now we have capillaries develop from these sinusoids that, again, feed the heart muscle. So coronary artery development happens from kind of day 32 of gestation, and there's the subepicardial vascular network that starts to develop. And there's these endothelial buds that appear in the base of the truncus arteriosus. And by day 45, there's a definite coronary artery circulation. And that coronary artery circulation is established and has all the different branches from the right and left coronary artery. And so there's two theories. One theory is this Abrikosov theory, and he's saying that there's two endothelial buds from the aorta form when there's this division of the truncus arteriosus. And so this is really the arch or the aorta of a baby chick, and we're seeing kind of two endothelial arches or buds form, and these two buds would form the right and left coronary arteries. There's also this Hackenceller theory, and this Hackenceller theory describes these endothelial buds in each of the six sinuses of the valsalva of the great arteries. So here are those kind of six sinuses, and as those sinuses develop, they all but disappear, but two of those endothelial buds. So there's it would go from these six. This would be the non-coronary, so there would be no coronary artery here, but then two buds, the left coronary artery and the right coronary artery, would form. So there is still kind of a debate, and these theories are debatable, but there is coronary ostia present by day 7 of chick development, and this ostia is connected via a vascular channel with that paratruncal ring, like we just saw on the Hackenceller theory. And each sinus receives multiple small vessels, and it's not clear whether there's a single channel that enlarges to form the coronary stem, or if multiple channels kind of coalesce and form a stem. And recent studies have kind of suggested that there's multiple channels and they coalesce and form that stem or bud of the coronary artery. Now we know coronary artery anatomy, no matter what segment division you look at. American Society of Echocardiography really uses, and the European Society uses, the 17 segment model. These are older models here, the 16 segment model and 18 segment model. 17 segment model is used today, and this is really dividing kind of base to apex, which are apical cap, right? So this will be the basal segments, the middle segments, and the apical segments, or mid segments, I should say, mid segments, apical segments, and this is the apical cap. And so knowing these territories, right, we can say anterior heart, posterior heart, and we can know the coronary distribution. And so we divide the heart into 17 segments, and we know where the coronary arteries mostly fill. And so we can look at these kind of chamber views, 4-chamber, 2-chamber, and apical long axis views, and cut planes through that 17 segment model. Again, base, mid, apical, apical cap. And it would go base, mid, apex, apical cap on all three of these images. And knowing each one of those segments, right, so basal to apical segments, we can now define which areas of the heart are getting blood. So let's say that you have, a basal, inferior, and mid-inferior myocardial infarction. So this area of the heart is not receiving blood. That area of the heart, we could say, well, that is fed mostly by the RCA, but it could be fed by the circumflex. So that is the next point. So now we have these two coronary arteries. So we have the right coronary artery and the left coronary artery. And the left coronary artery is going to bifurcate into the left circumflex and the left anterior descending. And as we look at that, we can see that these are kind of color-coded. Now, these are those 17 segment models. Let's just take the two-chamber view here. This would be inferior. This would be your apex, or inferior apex or apical segment, apical cap, anterior wall, anterior, mid-anterior, and then basal anterior. And so you can see these segments and you can say, well, these segments, these inferior wall segments, are mostly fed by the RCA. Sometimes I think it's really helpful to actually look at the short axis views. And so here would be the inferior wall, right? Anterior wall at the base. Here would be mid, right? Inferior wall, anterior wall. And again, we can see the right coronary artery is feeding those segments. The LAD is feeding the anterior segments and really the apical cap and apical anterior and apical inferior walls. So this is important because we can then say, what coronary artery is most likely caused. In the adult world, this is really important because we see a lot of patients with coronary artery disease, and then most likely which coronary artery is blocked. Again, we can see if we look at this loop model just shows that, again, the heart, all segments are being fed in this circle and half loop model. Segments either the right side or the inferior wall, the circumflex, and then the LAD. And so all segments of the heart, all those 17 segments of the heart are being fed. And just looking at normal coronary artery anatomy, we can see that there's a left main that arises from the left sinus. All right, so here's our left main. It's approximately less than 4 centimeters long, and then it divides into the left circumflex and the left anterior descending. And the circumflex, the size depends on if we have a posterior descending coronary artery, and we do, but what the dominance is. And usually the RCA is the most dominant, right? So we have, but you could have left dominance, and so left dominance would be 20% of patients, but RCA is the most common. And then the right coronary artery, again, the right coronary artery arises from the right aortic sinus of Valsalva, and then it has several branches. So the right coronal branch, sinus nodal branch, RV muscle branches, this acute marginal branches, posterior descending coronary artery, and then AV node artery, and then septal branches, all that feed the right side of the heart and the inferior portion of the heart. Now, inferior wall, infraseptal portions of the heart. And then lastly, and we'll talk more and more about some coronary artery anomalies later on in this semester, but let's move on to fetal circulation. So this is the last point in this week 2 lesson. So fetal circulation, the fetal cardiovascular system is designed to serve prenatal needs for development of the fetus. This includes modifications at birth that exist or establish the neonatal circulatory pattern. So in prenatal life, the lungs do not provide gas exchange, and the pulmonary vessels are vasoconstricted. Again, baby is getting all its nutrients from the mother. And there's 3 vascular structures that are important, or most important, in this transitional circulation. And so it's the ductus venosus, the foramen ovale, and the ductus arteriosus. And so if we look at that, and we'll talk about each one of those too, but we want to go through kind of this loop. So a small amount of highly oxygenated blood from the inferior vena cava remains in the right atrium and mixes with poorly oxygenated blood from the superior vena cava. This blood through medium oxygenation then passes into the right ventricle. And with those shunts, right, we have blood bypassing the liver and the lungs. And so it's not a closed circuit, because there still has to be the right ventricle has medium oxygenated blood, and that's pumping still, but there the lungs still have to develop, so they have to get blood, but there are these shunts that take place. And so again, those shunts are the ductus venosus, the foramen ovale, and the ductus arteriosus. Those are those three. And so the poorly oxygenated blood returns to the placenta for oxygen and nutrients through the umbilical arteries. And so as we look at this, right, here's the umbilical arteries. Here it'll go back to the placenta, pick up oxygen from our blood exchange from the mother. And so now we have this highly oxygen content coming back. And so it's coming back through the umbilical vein. And as it goes through, we can go into the portal vein here, but we have this shunt, and this is that ductus, the first one of those shunts, the ductus venosus. So here's that ductus venosus bypassing the liver, right? Bypassing the liver, going into the inferior vena cava, into the right side of the heart. Remember, we talked about formation of the foramen ovale, right? So here's that foramen ovale, and most of the blood is being directed past that foramen ovale to the left side of the heart. That left side of the heart then pumps that through the aorta. Aorta can reach to the brain, and then to the rest of the body here too, through the descending aorta. So that other shunt that we haven't talked about just yet is that ductus arteriosus, and I'm just going to point that out now. So there is some medium kind of oxygen content going through the right side of the heart, right? Lungs aren't, not that they're not developing, they're not functioning, right? Because we're getting the oxygen from the mother. So we have another shunt up here, this ductus arteriosus, shunting blood from the lungs. Again, these pulmonary arteries are going to be vasoconstricted. After birth, those three shunts that are short-circuited, the blood during fetal life cease to function, and then there's a separate pulmonary and systemic circulation. So there's after birth, those shunts then close. So I'm just going to show you this quick, from the, here's that umbilical umbilical artery. That becomes the ligamentum venosum. The foramen ovale closes, right? Becomes the fossa ovalis. And then the ductus arteriosus becomes the ligamentum arteriosum. But that's after birth. All right, so let's go through and get a little bit more detailed on fetal circulation. So we get highly oxygenated, nutrient-rich blood, returns under high pressure from the placenta in the umbilical vein. It approaches the liver, and approximately half of the blood passes directly into the ductus venosus, a fetal vessel connecting the umbilical vein to the IVC, and then the other half of the blood flows in the umbilical vein, from the umbilical vein, flows into the sinusoids of the liver, and then enters the IVC through the hepatic veins or the portal system. So both one shunt, half the blood going through the ductus venosus, the other half going through the liver, all coming together to the vena cava. So here we go. Here's the baby. Here's fetal circulation. Here's the placenta. Here's that umbilical vein. Umbilical vein going to the ductus venosus. As we see that ductus venosus either going into the IVC or that half the blood going into the liver and then through the IVC here too. Here's just, again, a picture of the ductus venosus. Again, this shunt. Okay, so shunt going directly from the umbilical vein into the vena cava, or inferior vena cava. Blood flow through the ductus venosus is regulated by a sphincter mechanism close to the umbilical vein. We saw that sphincter in one of those slides here. When the sphincter contracts, more blood is diverted into the portal vein and the hepatic sinusoids, and less into the ductus venosus. So more blood would be going through the liver to the IVC and then to the right side of the heart. This concept is not universally accepted, but there is a physiologic sphincter that prevents overloading of the heart when the venous flow in the umbilical vein is high. After a short course in the IVC, then the blood enters the right atrium of the heart. The IVC contains poorly oxygenated blood from the lower limbs, the abdomen, the pelvis, and then the blood entering the right atrium is not as well oxygenated as that of the umbilical vein. Remember that umbilical vein has highly oxygenated blood, but even though that IVC contains some poorly oxygenated blood, that blood is mixing and it'll still have a high oxygen content. Most of the blood from the IVC is directed by the crista dividends through the foramen ovale into the left atrium. Remember, there's that communication in the right atrium or communication in the atrium of the heart. This again mixes with a relatively small amount of poorly oxygenated blood returning from the lungs through the pulmonary veins. And then the fetal lungs use oxygen from the blood instead of replenishing it. Again, the baby is not, the lungs are forming after birth, then that circulation, that pulmonary circulation exists. From the left atrium, the blood then passes to the left ventricle and then leaves the left ventricle and passes through the aortic valve to the aorta. So here is this foramen ovale, right? So again, blood is being blood is being directed into the left atrium. Here's that crista dividends, right? So blood coming through the IVC. Again, some blood is coming through the superior vena cava, but highly oxygenated blood is coming through the vena cava or inferior vena cava, going into the left atrium. Some blood is coming in through the pulmonary veins, and then it would go through the mitral valve or the developing mitral valve to the left ventricle, out the aortic valve, and the aorta to the rest of the body. So arteries in the heart, neck, head, and upper limbs receive well oxygenated blood from the ascending aorta, and the liver also receives that well oxygenated blood through the umbilical vein. Here's an echo image of that too. Umbilical artery, umbilical vein, and here's that ductus venosus. This is a fetal ultrasound image. A small amount of that well-oxygenated blood from the IVC in the right atrium does not enter the foramen ovale and then poorly mixes with the blood of the SVC and the coronary sinus, and then remember it passes into the right ventricle. This blood has a medium oxygen content and leaves through the pulmonary trunk. Approximately about 10% of the blood flow goes to the lungs. The rest passes through that third shunt. So most blood passes through the ductus arteriosus into the descending aorta of the fetus and returns to the placenta through the umbilical arteries. And that ductus arteriosus protects the lungs from circulatory overloading and allows the right ventricle to strengthen in preparation for functioning at birth. Again, after birth, now we have those closed circuits, the pulmonary circuit and the systemic circuit. Because there's high pulmonary vascular resistance in fetal life, pulmonary blood flow is low. And again, that 10% of blood from the ascending aorta enters the descending aorta, and 65% of the blood from the descending aorta passes into the umbilical arteries and is returned to the placenta for reoxygenation. That other 35% is of that blood in the descending aorta supplies the viscera and the inferior portions or parts of the body as they develop. All right, so as the viscera, the other vasculature, lower limbs, right, still need blood, so it doesn't just get circumvented back to the placenta. Blood is being blood is used for development of those lower structures. Again, so here is the circulation that you need to know. So again, know from placenta, know the different shunts. Okay, so ductus venosus, foraminal valley, ductus arteriosus. Be able to follow the blood flow, right? Be able to follow the blood flow throughout. You won't be, because this is fetal echocardiography, you're not going to be quizzed on afterbirth, but I would know the different parts and know them now of what becomes of the ductus venosus, what becomes of the foraminal valley, what becomes of the ductus arteriosus. So here are the references from this lecture, from the week 2 lecture, and this kind of really concludes that of human heart embryology. I know there's a lot of different concepts. Be able to take the main points of this for development. And this is going to help you again as we go through and go through different abnormalities coming up in the following weeks. Again, this is week 2. There is a quiz this week, so make sure you take that short quiz. Be sure to go to the Moodle site and take that quiz this week. Again, think about the main concepts with going through this embryology. Again, this is going to help you with these abnormalities in the future. Thank you very much for your attention and look forward to speaking to you all soon. Thank you very much.